Hello and welcome to our third Health Services Researcher interview. My name is Rachel Morton and I'm a Professor of Health Economics at the University of Sydney and President of the Health Services Research Association of Australia and New Zealand, or HSRAANZ for short. Our interviews have been focusing on HSR during COVID-19. Today we will look at what we know and don't know about the health systems response required to manage the aftermath of the pandemic and minimise collateral damage. My guest today is Professor Kathy Egar. Professor Egar is Director of the Australian Health Services Research Institute and is involved in all aspects of the Institute's work. She has over 35 years of experience in the health and community care systems, during which she has divided her time between being a clinician, a senior manager, and a health academic. She has authored over 350 articles, papers and reports on management, quality outcomes, information systems and funding of the Australia and New Zealand health and community care systems. Kathy, thank you very much for joining us today.
Thank you.
Can you begin by giving us a bit of background about your current research interests and how they've been impacted by the COVID-19 pandemic?
We at ASRI have got 6 research centres, and the impact for me and for ASRI more generally sort of varies a bit across the 3 centres. We run the 3 Australia New Zealand centres in patient outcomes, and we have a lot of long-term, and I have a personal interest in looking at patient outcomes in chronic disease. And over time, I think if I was to say how my research interests have changed, I've sort of moved away from acute care because I think it's very straightforward to being much more interested in chronic and complex care, because I think it's most conceptually more interesting, and I actually also think it's the future of healthcare. So in PCOC, the National Palliative Care Outcomes Collaboration, in AROC, the Australasian Rehabilitation Outcomes Centre, and in EPOC, the Electronic Persistent Pain Outcomes Centre, we've really started very early, back in March, to build in routine collections to understand the impact of COVID and what does that mean for referrals and the types of patients either coming to or no longer getting palliative care, rehabilitation and chronic pain services. And that's both the cohort who got referred to palliative care because of COVID, but also in those 3 streams are patients at very high risk and who are therefore very vulnerable if they do get COVID. So we've actually implemented from the 1st of April a national palliative care outcomes collection for COVID. And we could do that in a really nimble way, well ahead of what anything government could do on a national basis, because it was a group of us who just got together and rolled it out. And we actually had 180 sites all start collection on the first day.
So you've been looking at sort of specifically the opportunity cost of deploying a lot of resources into acute care and testing, treating and management of respiratory problems, and so you're looking at the impacts on people with non-COVID conditions. Is that
I think
a fair summary?
Certainly for ASRI, there's been 2 impacts. One was for the outcome centres, there was a lot more work to get those collections. For some of our other centres, of course, where we had observational studies in progress, those studies got suspended. We've been doing a lot of work in residential aged care, and that's all been locked down. So we've had a lot of juggling. We're really quite pleased with ourselves because we're still on track to meet our funding goals and publication goals for this year.
Excellent.
But that's part of what happens when you get to be large enough that you've got a critical mass. But certainly coming back to the COVID issue, the good thing I think we've got in health services is how well Australia and New Zealand has done. I mean, we really can take our hats off and be very pleased with ourselves that by a combination of good management, good luck and good geography, we've really escaped the first wave. And yes. I am somewhat amused when people talk about the second wave when we didn't actually we got a little ripple compared to everybody else.
That's for sure. We're certainly very fortunate. So speaking about those waves, one of the things that find quite interesting at the moment are the so-called human-centered waves of a pandemic, as described by Victor Singh, and how they can be applied to our experience of the pandemic. Do you have any thoughts on that particular framework?
Yeah, we've taken Victor's work and we've been further developing it for our situation. And I might just run through what those waves look like, because some people might not be familiar with it. So wave one is the immediate impact of having COVID, and Victor Zhang is an intensivist, so it's obviously looking at mortality, morbidity in that 10% of people who become really, really unwell. And we've really amended and developed that further to say there's a wave one tail we now need to understand. What is the post-acute care and the rehabilitation requirements for that acute COVID group? Mm-hmm. And I think what we're starting to see is a whole lot of complications that are possibly there for 5% of the cohort going further. 90% of people will be fine, 5% will be extremely unwell, but probably 5% may well have long-term implications. And in my own region, where one of our centres is a regional data linkage centre we run, we're already proposing to create a COVID flag for anyone in our region who's had a COVID test, positive or negative, so that we can then look at that cohort over the next 5 to 10 years. So the second wave for us is the impact of both community fear and resource restriction on urgent non-COVID patients. So we've seen a significant reduction around Australia and internationally in areas like people starting cancer treatment.
Yes.
Perhaps people with chest pain not presenting to the emergency department when they might have with stroke, both because a lot of services were closed, but also that people have been very fearful. And we've got some evidence coming through of 30 and 40% reductions in emergency department attendances. And what we actually don't know whether is that was good because they really didn't need to come anyway, or whether what it's actually done is to delay treatment and care for a cohort who did have urgent non-COVID conditions, and what does that mean for them going forward? So that's our second wave. Our third wave, which is a particularly strong interest for me, is the impact of COVID on interrupting the care for people with chronic conditions. So patients who had a stroke, got their acute care and didn't go to a rehab unit because everything in subacute care was pretty much put on hold and resources set aside to actually create the resources required urgently for COVID. But I do think there's a big issue about the interrupted care for people with chronic conditions, people at risk of falling, the frailty cohort, the rehab cohort, the patients with chronic and persistent pain who won't start pain. Most of the outpatient clinics in Australia were cancelled. And that means a whole cohort with musculoskeletal conditions not going to allied health clinics, etc., etc. And then the fourth wave is really the emotional and mental trauma cohort. And in that group, I'd put mental illness. And it's interesting that the National Mental Health Commission is saying that they can see no evidence of increased suicidality in Australia, which is not what's being reported elsewhere. But of course, the figures everywhere are really unreliable.
Preliminary.
And very preliminary. But we already do know that there's been a massive increase in domestic violence, in substance abuse. But there's also been some offsets, like, people with gambling habits, couldn't get access to poker machines and those sorts of things. But essentially in that fourth wave, I would put mental illness, sort of trauma, and particularly in Australia for us. And I live in a region that really had the impact of the bushfires. So people came straight out of a bushfire trauma and then lost their tourist season. And now they're dealing with losing their jobs. So unemployment. And I guess the other thing I'd say is that compared to a lot of other conditions and a lot of other countries, our patients with COVID look like they actually come from the wealthier suburbs and the wealthier parts of Australia, because most of our cases were linked to overseas travel.
Yes, people returning from vacations or business trips.
Yep. Yeah. And so if I look at something like America and the UK, COVID is disproportionately completely allied itself again with the social determinants of health.
Yes, yes.
But we haven't seen that in Australia. It's quite the reverse. The hotspots of COVID have actually been suburbs and parts of Australia with high socioeconomic status, not low socioeconomic status. So in Sydney, for example, you know, the hotspots have been the northern beaches and the eastern suburbs. And there have been others. But I do think that that's a different phenomena, and that's quite likely to have an impact and allows us to do some important international comparative work going forward as well.
Yes, that's for sure. I mean, it sounds like this four-way framework is actually a really useful framework for analysis of a whole lot of policy response as well, and the impacts of those policy, possibly also research funding that has been dedicated to particularly the acute care and the prevention vaccine strategies as well. I'm sorry.
Yeah, I guess what I just wanted to say on that, what I think we've seen so far is two responses. One is a good improvement, which has been telehealth and a massive take-up of telehealth.
Yes.
The second thing, though, we've seen is that we've been working for 20 years, or certainly I have, to try and get a more balanced investment across the health system. All of a sudden, all the planning for COVID was about intensive care units and machines that go ping. And I actually think we've skewed the health system back to a focus on acute care and high technology. We have thousands, literally, of ventilators in Australia that we will never use. And all the planning's been done for the acute component with real neglect of those other waves.
Yes, and we'll be able to sort of evaluate what the longer term impacts of that have been. I will come back to ask you in a minute what you would like to ask for if you had the opportunity. But before I do, just thinking a little bit more about perhaps the next phase of our experience with COVID-19. As you say, Australia has been very fortunate. We've flattened the curve in terms of, ICU demand. And controlled the immediate impact of the virus. But as we move into the next phase of easing social restrictions, what short and long-term impacts do you see for those people you mentioned before with chronic conditions, including mental health conditions? And how might we minimise that impact?
Certainly in the work I do internationally, the international group doing world projections do not project that Australia will have a second wave, and I don't believe we will either. And I think our future, at least between now and when the borders reopen, is to understand COVID as a hotspot problem. We're going to have a little cluster breakout here and another cluster breakout there, and we have to learn. And I actually think a lot of the services planning we're doing is wrong, because we're planning for a second wave, which I don't believe will come. But I don't believe we're planning adequately for the management of hotspots.
Yes, okay, that's a very good point. I wanted to also ask you about the World Pandemic Research Network. You're involved in this network. Can you tell us a little bit more about the platform and how HSRAANZ members might utilise it?
Yes, the World Pandemic Research Network has been an international collaboration. It's just been set up literally in the last 2 months. I am one of the reference for Australia. It's really looking at becoming a global searchable directory platform for researchers and others interested in the research results, not in the laboratory clinical component of COVID or any pandemic, but really looking at the social impact and the aftermath. So it's a searchable database, and if you want to look at go back to some of those waves, if you wanted to look at the long-term impact on gamblers or whatever, you would register your project. You'd be able to search there worldwide to see anybody else doing that. And the idea is that people like myself are the reference who actually do a first peer review at the design phase and put it up there. And that's partly because everybody who's involved, the research community internationally, understands that the traditional process that you don't actually put it up for publication until you complete. We have to actually design and build and construct and learn as we go.
And share that more openly.
And share it more openly. So it is called the World Pandemic Research Network. It's a platform. Anybody involved can go and search on it. There's already hundreds of projects that have been registered, and I'm very strongly urging Australian researchers to register your project and to use it to find like-minded researchers worldwide where we can actually share this sort of work. There's an obvious caveat, of course, which is that Australia and New Zealand have largely escaped the COVID bullet compared to other countries. But that also gives us an important opportunity to do some comparing and contrasting.
It does, and it gives us some space and ability to actually focus on, what is not acute management or research that's not based on, mortality outcomes per se. We're probably in a good position to reflect and compare, as you say. And is that platform, does that also have projects that are being undertaken in low and middle income countries?
Yes, all over.
Yep.
So there's a lot of people. I've had an appointment advisory role with WHO for a couple of years in terms of rehabilitation as part of universal access to care. There are other people who've got links to WHO in various ways, but also just others internationally. If you have a look on that website, you'll actually see that there is a board of very eminent researchers from all around the world, and then there's about 100 reference, of which I think I'm one, there's a handful from Australia.
Excellent, thank you.
Trying to get as many people as possible to participate.
It sounds like a wonderful initiative, and certainly one of the the real opportunities that's come forward in terms of the way we collaborate internationally and the speed at which we can foster that collaboration as well. Kathy, I wanted to ask you what you think the role of health services research is, or what role can it play in ensuring that we, like that initiative you spoke of, that we improve rather than just recover the existing health services. So following the current disruption, what role do you think health services research can play in ensuring we improve rather than just go back to where we were beforehand?
I think one of the things we need to be really clear is to start to look at what sort of primary care system do we want going forward. I'm not at all convinced that we've got the telehealth items right. And I think one of the things we health services researchers can do is to really look at what's going on in that space. And I suspect that what they're going to become is very, very many, very short consultations to write a script. Rather than an engaged way of working with patients going forward. So I think there's a whole piece of work that the health services research community really needs to be involved in, looking at what is a good primary care service going forward, where you can link up face to face and telehealth. And the other thing, of course, that will do is that it'll send care back to being about one-to-one relationships rather than team-based care. How do you actually engage in multidisciplinary out-of-hospital care in a telehealth world? So I think that's one really big area. The second area in terms of COVID and hotspots, I think there's a really basic question we don't know the answer to. Are we better to designate a small number of hospitals as COVID, or better to try and ensure that every hospital's got the capacity to do a little bit of COVID care?
Yeah, great. That's a great question as well.
I think for
centralisation or decentralisation of COVID services.
Yeah, so every hospital's obviously going to have the capacity to screen for it. But at the moment, we have hundreds of hospitals that are running at low levels of occupancy, either because their resources have been quarantined for COVID or because patients are too frightened to go there.
Yes, absolutely. And so now coming back to the real pinch point in terms of research funding, particularly for health services research. If you had 2 minutes with government funders, government health research funders, what would you say or what would you ask for?
I would always punt for more money for subacute care research.
Mm-hmm.
Who are the patients who really would benefit, who have chronic and complex care conditions for whom acute episodic care is not enough? And how do we stop, how do we put the circuit breaker in repeat reattenders in hospitals? And what is that going to look like in a post-COVID world? And we have to have smarter ways of doing that. I think the second sort of area for me is in mental health.
Mm-hmm.
And given that we know that most of the mental health problems are driven by social and environmental factors, including climate change going forward, and social and economic determinants like unemployment, is it actually really useful to invest in mental health service? And if so, what should they be doing?
Yes,
I'm not sure at all we've nabbed, when that's the cause of the mental health problems, a whole lot of traditional clinical services, I don't believe, is the solution.
The treatments are not addressing the fundamental problems.
And I think the third issue for me is Australia and New Zealand are victims of our own success, in a sense, in the prevention space. We've now got a sizable proportion of people going into old age. And what does a better aged care and social care system look like? That isn't just about putting people in residential aged care services and forgetting them, which has been what Australia's done for the last 20 years.
Yeah, absolutely right. Gosh, fantastic. I do hope you get that opportunity soon to ask for those three things, all extremely important issues. Kathy, thank you very much for your time today. I wish you all the best with your research, both COVID related and COVID unrelated. And that brings us to the end of today's HSR interview. Thank you for listening, and please refer to the HSRAANZ website for details of this podcast and the next interview in the COVID-19 series.